We use maintenance therapy for other B-cell malignancies. Maybe, Nicole, you can comment on, is there value in, just briefly because we're going to move into the relapse setting, is there value to maintenance strategies? What's been tested for maintenance in CLL? And
we haven't done this as much in CLL as we've done in the non-Hodgkin's lymphoma, such as follicular lymphoma settings. There have been some studies looking at maintenance, both with lenalidomide and also rituximab, and certainly there's no doubt that when you continue additional agents as maintenance, there's sort of depending upon the response after the therapy they might have gotten as their initial therapy, we can see an increase in response efficacy, but the question always comes up with how long the duration should be. Are there increased side effects with long-term maintenance depending upon the drug? There have been some, lenalidomide, for example, can give some cytopenias and so on and so forth. So there's always, how do you grapple with some of the potential toxicities? So probably most frequently, if it's done with an antibody in practice. And I think we do see this a lot in the community, where a lot of physicians are sort of similar to what they're doing for their non-Hodgkin's lymphoma patients or their follicular lymphoma patients. They're giving rituximab as a maintenance for some of the CLL patients, and so we do see it. But do we have really great data or a lot of data? No, we do not. So I think it's something that's certainly something we can consider doing. I guess it depends on how you look at these monotherapy approaches with the TKIs. If we're going to continue them indefinitely or not as maintenance, if you want to consider it that way. But I think this is one area that we just need to delve into more in detail, and certainly if you're going to truncate therapy to begin with or reinitiate therapy when patients are MRD positive, do you need that? So I think that it's just an area that we have a lot more digging to do.
I mean, if we're talking about maintenance with ofatumumab or lenalidomide or rituximab, regardless of what the trial showed with ofatumumab, I strongly discourage it. We're in a new era. That was post-chemo immunotherapy. We have much better drugs. I would not do that.
And also those studies were typically in patients who had been relapsing on a second-line chemo immunotherapy.
Second line,
right? Those are patients we'd be targeting novel agents for now.
Correct. So it's just not done.
Bill, before we move on to the relapse setting, I think maybe we can discuss the ultimate question for Frontline, ibrutinib versus chemoimmunotherapy, which is a better starting point, right? We always get this question from our colleagues and also from our patients. So I know there are a number of ongoing randomized studies, so really the answer will really come out from those randomized controlled trials to compare ibrutinib-based therapy, either alone or in combination with anti-CD20 antibody versus your standard immuno-chemotherapy. So just want to point out a couple of them. So the ECOG 1912 study, which is for younger patients comparing ibrutinib plus rituximab versus FCR. The Alliance study is for older patients that's comparing ibrutinib alone versus combination with rituximab versus BR. And then there are a number of studies in Europe ongoing. I think the CLL 13 study from the German study group is comparing a number of novel combinations, including ibrutinib-based combinations, venetoclax-based combinations, novel therapies, versus your standard FCR-BR, and then there are UK studies. So there are really a number of randomized studies ongoing.
Absolutely.
But in this ASH, there is one abstract that's very interesting. So Dr. Roback did a retrospective analysis. So he was pulling data from several really large randomized trials, including the CLL 8 and CLL 10, to get the patients treated with FCR, patient treated with BR. He also put data from CLL 11 for patients who were treated with R chlorambucil versus G chlorambucil. And then also data from the Resonate 2 study to get the ibrutinib arm. So he was doing to put all of the immunochemotherapy patients together and look at those patients versus patients who were treated with ibrutinib as a frontline therapy. So based on his pooled analysis, it looks like patients who were treated with ibrutinib appears to have a longer progression-free survival. In addition to that, for elderly patients and frail patients, those patients also seem to have improved overall survival comparing to immunochemotherapy. And from toxicity point of view, despite the much longer drug exposure time with ibrutinib, compared to immuno-chemotherapy, this toxicity profile is also very favorable with the ibrutinib-treated patients. So that's definitely generating very interesting signal, but I think the ultimate answer will come from the randomized clinical trials.